Hello, Dr. Bouldin.
Hey, Dr. Knapp, how are you? Hi, Jay.
Great. Sorry, let me pause this. Well, good evening, everybody. Thank you for joining us for the Center for Long-Term Care webinar. And I'll introduce Dr. Erin Bouldin in a second. I just first want to acknowledge some people who've helped make our webinars possible. Thanks to Cindy Jakubowski, who's Administrative Secretary in the Department of Public Health, Stefano Bonani, who's Administrative Director of Operations in the School of Health Sciences and Practices, Dean's Office, MPH GA, Sylvia Bandia, and Lama Bettis, DRPHRAJ Ayar, Michael Frankfurter in Educational Media Services, and our Center for Long-Term Care Advisory Board, Susan Fox, Carol Levine, Melissa Lang, Michael Majax, Mark Kittleson, who is the chair of the Department of Public Health, the Dean's Office, Dean Rob Amler, and Vice Dean Ben Johnson. Thank you all very much for helping make this possible. And I'm very excited about Dr. Bouldin's presentation today on an important data set. She presented, I think, last year on another data set, behavioral risk factor surveillance system. But just first, a couple things. This is being recorded, and the recording will be made available on the Center for Long-Term Care website. And let's please all mute ourselves. I'm glad I said that because I forgot to do it. And if you have a question, unless it's something that needs immediate clarification, just hold all questions for the end. And you can just raise your hand or send a chat, and either Dr. Bouldin or I will call on you. So the title of Dr. Bouldin's presentation is Understanding the Needs and Experiences of Family Caregivers and Their Care Recipients Using the National Health Aging Trend Study, also it's NHATS, and the National Study of Caregiving. Dr. Bouldin is an associate professor at Appalachian State University's Public Health Program, where she teaches in the bachelor's degree program in public health. Her research interests include family caregiving, cognitive decline, and rural health, all of which stem from her desire to discover factors that impact disability and function and intervene to minimize impairments and promote population health and participation. And we're very lucky Dr. Bouldin has served on a few of our DRPH dissertations, and she's just fantastic, a great colleague, extremely competent, and extremely nice. So Erin, thank you very much for taking the time to present today.
Thank you, Dr. Knapp. Thank you all for being here, and thank you to the Center for Long-Term Care for having me. It's always a pleasure to see you all. So I'll go ahead and start sharing my slides. So as Dr. Knapp kindly introduced, I will be talking mostly about family caregiving, but I will say that those of you who just have more general interest in aging will hopefully find this useful. So I am going to talk about these two data sets that are connected, the National Health and Aging Trend Study and the National Study of Caregiving. And before I launch into that, I didn't do a poll or anything, but how many of you are familiar with these data sets already? Raise your hand or use the hand.
No, I have not heard of the national, the NSOC, and I'm pretty interested as a geriatrician. So I hope to learn more.
Excellent. Yes, great. Has anyone used these data sets before? Okay,
Nope.
well, sorry, go ahead.
No, I was going to say no, I haven't, so I'm interested.
Okay, excellent. Well, I will give you my disclaimer up front, which is I have only used them, I learned them over the summer and then just worked with a team to sort of do our first set of analyses. So I'm pretty new to it, but I've been admiring them for a while. So I'm going to share what I know about them with you and give you some resources, because the wonderful thing about them, in addition to the great data that they contain, is that there is really excellent support for researchers who want to use these data, and they are available to researchers. So it might be a resource that you all want to use going forward. So before I launch into the details about the data sets, I just want to mention the objectives here. So I'm going to talk about family caregiving briefly, just because I'm assuming that most of you probably are familiar with the concept, but it may not be your specific area of interest. So I'll just set the stage a bit, but not go into too much depth. And then I'm going to spend most of the time talking about what's actually in the two data sets. So the National Health and Aging Trend Study, which I'll call NHATS, and then the National Study of Caregiving, which I'll call NSOC. So I'll tell you about what the purpose of each one is, sort of how long they've been around, how they work, what the sample looks like, and then what types of questions are in there. And then I'll point you to where you can find more details, and then talk about how to access the data and use them. I'll wrap up with just a couple of quick examples of some of the types of work that's already been done using these data sets, and then again, point you to where you can find out more about that. So as Dr. Knapp said, I'm happy to answer questions, and feel free to ask them along the way, or we can chat in more depth at the end. So first, a brief introduction on family caregiving. So who are we talking about here? When I use the phrase family caregiving, I mean people who are helping older adults or people with disabilities at home in the community. So this could be actual, kin, relative kinds of family members. It could also be friends, neighbors. They don't necessarily have to share, a formal relationship, but we kind of capture all of those types of caregiving situations under this family caregiving umbrella term. So usually these are people who are not paid to do the work, so it's not their regular job. Of course, the asterisk is that there are now some programs, notably the VA programs, pay caregivers to do this work. Nonetheless, they're still kind of considered family caregivers. And so we often think about these family caregivers as providing kind of the backbone of long-term care in communities. Again, the caregivers can really enable people to age in place, age at home, live at home with a disability. So they commonly provide really complex care in the care recipient's home. Sometimes they live together, sometimes they don't. But again, this is focused on people who live in the community, which could also include in assisted living facilities, even in long-term care settings, but people coming from the outside who aren't employed by the long-term care facility, for example. And it's noteworthy that there are a number of different kinds of home and community-based services that can reduce caregiver burden. And so this could include things like home delivered meals, having a home health aide come in, or just having somebody come in and do some housekeeping kinds of services. It could also include respite for the caregiver, so someone who is formally trained, who can come in and give them a break, or someone who's trusted. So caregiving has, it's kind of a balance, like so many things, but there are some positive aspects of caregiving, and increasingly, I think people are giving attention to the positive aspects of caregiving. Those might include things like feeling closer to the care recipient as a result of providing care, having a sense of purpose, or feeling confident that your loved one is getting the kind of care and attention that you want them to have. It can also, because caregivers often are doing these complex tasks and sometimes medical kinds of tasks as well, it can bring a sense of mastery once you've learned how to do those and you're executing them well. There are also some negative potential consequences of caregiving. And so burden is a big one. I already mentioned it without defining it, but that's essentially kind of like role overload, just feeling stressed or overwhelmed or unprepared in the caregiving role. And so there's been a lot of work to show that experiencing burden, having high levels of burden, is associated with poor health outcomes for the caregiver. In some cases, in some studies, there's been an association with mortality for caregivers. So it is a problematic kind of byproduct of providing care. Also, caregiving, if you're providing care to someone at home, it might interfere with your work, which can then have financial consequences if you need to cut back on work hours or leave the workforce altogether. It can also interfere with social activities. And then there can be a financial impact beyond just the work-related one. If many caregivers end up supporting the care recipient financially or helping pay for medical services or transportation or other things, paying out of pocket for some of those home and community-based services sometimes. So there are a number of different potential positive and negative consequences or experiences that family caregivers might have. There also are, of course, a whole host of neutral ones. Much of the work of caregiving can be spending time with the person and doing household kinds of tasks and things. So that is just a broad strokes picture of what we know about family caregiving experiences and kind of how they might fall on this positive or negative spectrum. I'll also note that there is evidence that the kind of balance between positive and negative perceptions of the caregiving role do vary based on demographic characteristics. So I think the largest difference I've seen has been by race and ethnicity. There's also some evidence to suggest that it's different based on your gender and other factors. So, none of this is completely consistent across the population of family caregivers. So there is lots of variation in the experience. So caregivers themselves have a number of needs potentially. So training is a big one, especially again, if a caregiver is providing more medical tasks, doing things like wound care or helping transfer someone, bathing or dressing someone. They also often need some more training or information about disease course. So dementia is maybe the one that comes to mind most quickly, which, there are we expect dementia to be, the disease process of dementia typically involves increasing loss of function over time. And so helping caregivers understand what that process looks like and how their role might change over time is an important part of the training for providing that kind of support. Caregivers, again, themselves need some support. So they might need social support either through informal networks that are existing or through caregiver support groups or some of those formal services. So again, having somebody like a home health aide or home care nurse services can be helpful. They also might need breaks from caregiving, and they might need help with accessing healthcare. So whether that's insurance or actually getting to medical appointments for both the care recipient and then themselves. So there's some data to suggest that caregivers forego their own medical care, especially routine screenings and things like getting flu shots. So that may happen as a result of taking on the caregiving role. As I mentioned in the context of dementia, but really it applies to all caregivers, there are changes in their needs over time. For most conditions, most disabilities, the care recipient's needs are going to change over time, which means that the caregivers will as well. So I think that's just important to recognize. And so it's helpful to have longitudinal data to be able to look at that, to kind of see how does burden change over time, or are there inflection points in caregiving that are associated with poorer outcomes, for example. And then this last bullet on here is a vast oversimplification of a number of different models, but effectively, you can imagine that if the caregiver has unmet needs or really high levels of burden, that can result in the care recipient having unmet needs. So for example, the care recipient may go without being transferred or without being bathed or without having the kinds of medical care they need if the caregiver kind of can't meet those needs. It can lead to other poor outcomes for the care recipient. So you can imagine injuries, dietary problems, that sort of thing. And also having a caregiver who becomes overwhelmed and can't continue providing care can lead to institutionalization for the care recipient. So a number of different outcomes that might occur if caregivers aren't supported adequately and if they experience too much burden or too many negative consequences of caregiving. So I'm going to jump into the data now. Are there any questions, comments on the basic overview of caregiving and why it matters before we move on? Okay. So I'll jump into the NHATS and NSOC discussions. As Dr. Knapp said, I've talked before about the behavioral risk factor surveillance system, which has a caregiving module. So it provides some public health surveillance level data about caregiving at the state level. So that's a great resource. The National Alliance for Caregiving does a survey every couple of years and makes that publicly available. So there are other data sources relevant to caregiving that I'm not going to talk about today, but if you have any questions or interests about those, I'm happy to discuss them offline another time. So we will just be talking about NHATS and NSOC, and I'm going to do them in that order. So NHATS, again, is the National Health and Aging Trends Study. It started in 2011, so that was the first year data were collected, and it's funded by the National Institute on Aging. So currently, Vicki Friedman at the University of Michigan and Jennifer Schrack at Johns Hopkins University lead the NHATS project. Judy Casper was formally involved when it first started. And the goal of NHATS, I'll show you kind of the conceptual framework in just a minute, but it really is to understand the experiences of older adults as they age, and really with a focus on kind of function, participation, disability. So the sampling frame is Medicare beneficiaries, and I think something like 96 or 97% of all older adults in the US are eligible for Medicare or enrolled in Medicare. So it essentially captures all older adults in the US. The way that they sample, there's approximately equal numbers of people in, I think they're like 5-year age groups. So effectively, that means that older adults are oversampled because there tend to be, more people in the 65 to 70 range than in the 90 plus. But the distribution within NHATS is such that, each of those groups is approximately the same size. They also have intentionally oversampled Black non-Hispanic older adults. And that's really just so that it's possible to kind of look at that demographic group specifically. And I believe this year, so 2021, so as it says here, the NHATS started in 2011. In 2015, they did a sample refresh. So they enrolled some new people to replace people who had died or left the study for other reasons. And there's another one happening this year in 2021. And so I believe with the 2021 sample, they are also oversampling Hispanic older adults, again, so that there's an adequate sample size that you can focus just on that subset of Medicare beneficiaries. So it's done annually, NHATS is done annually, and it is an in-person interview. And so it's either with the enrollee, the Medicare enrollee, or if they're not able to complete the interview, either because of something like cognitive impairment or because they died in the past year, then proxies are used in their place. But even with proxies, it's an in-person interview. So if you go to nhats.org, there is data available there. So you do have to register for an account, but it is free to researchers. And then once you kind of have your account established, then you can actually download data directly from the website, at least the de-identified publicly available data. And I'll talk more about the restricted data sets later. I am going to just click on this video tutorial link real quick so you can kind of see that they have a wonderful, and I do recommend, this is kind of how I got started. I watched all of these videos. And so they're relatively short. You can see they're kind of like 5 to 10 minute long videos, but it just tells you about what's in the files, how does the study work, how do you access things, and then what kind of supplementary data they have available. So that's for NHATS. And then if you keep scrolling down, there's the same kinds of videos for NSOC, the caregiving specific one. So it's a really nice website, easy to use, and the tutorials are great. So I recommend that if you're interested in giving this a try, that you start there with those videos. After you can view the videos without registering for account. They're on the public site, but go ahead and register and then check those out. So Imran, it looks like you might have a question.
Yes, I do. Does the data focus on different disease states, or it's just in general?
No, it is just general. So let me scroll down. So there are questions about, I'll come back to this in a second. So there are questions about what people have been diagnosed with. So if you're interested in a specific, like people with heart failure or people with dementia, there are specific questions about people's diagnosis history. And then because it's an in-person interview, there's like a cognitive battery. So it includes like self-rated cognitive function. And then they ask, for the date, there's a clock drawing portion of it, and then some word recall, and then asking about the name of the president and vice president of the United States. And then there's some physical function tests that are done. So those are listed here also. So you can kind of classify people as having different levels of physical and cognitive function. And then again, it's just self-rated or self-reported health conditions that they've been diagnosed with. I think there are some blood spots done, but I don't actually know the details about what's included in those. So you would be able to, yes, while the overall sampling frame is just anybody enrolled in Medicare, you, depending on your particular interest, could focus on, the subset of people with specific conditions or functional levels.
I asked that because my area is a geriatric cancer, so older adults with cancer, and the challenges caregivers have with taking them to chemotherapy or side effects.
Yeah, and so you would certainly be able to get at that, and they do ask some details about the type of cancer for the participant, and then I'll share a little bit more about NSOC and what the caregivers get asked. I don't think there's anything specific to chemotherapy, but you might be able to get at some of the medical kinds of tasks through there. So great, thanks for that question. Yeah. Any other questions right now? Okay, so let me just briefly show you the conceptual framework for NHATS, and this was Vicki Friedman published this article in 2009 that's kind of setting up the framework for the study. And if you're familiar with the ICF model, so the International Classification of Functioning, Disability, and Health from the World Health Organization, this looks very similar. And the title of the article indicates that it's kind of an adaptation of the ICF model. And so this, everything that's represented here in this figure is data are collected on these concepts in pretty good detail on NHATS. So, you can think about the environment. So they ask about both the physical environment, the social environment that people are living in. There are some interviewer rated aspects of the neighborhood. So again, because it's an in-person interview that happens in people's homes, that interviewers record things about what the neighborhood conditions look like, and those are in the data set. As I was just talking about, there's information about health conditions. I haven't talked about these yet, but there are questions about specific impairments that people have in body functions and structures. Also, their capacity to do different tasks along with any accommodations they use. There are questions about home modifications and assistive devices that people use. And so all of that kind of then impacts the activities that they actually carry out, and then how much they participate in society. And so in the ICF model, and when I talk about participation, it really means just kind of social engagement. So that could be work, that could be volunteering, that could be seeing friends, going to church, any kind of engagement with the broader social community is kind of what participation is getting at. So that, again, is the framework. And that's where a lot of, I would say, the majority of the questions that are included in NHATS fall within one of those domains. So I've already kind of mentioned some of this, but so there is information about the person's residence. And so I'll also add, people don't have to be community dwelling to be included in this study. So again, it is just a sample of Medicare beneficiaries. So there are people who at enrollment are already living in a long-term care facility. There are people in assisted living facilities, and there are people in their own, homes in the community. So there's information about where someone's living, who they live with, what the condition of their neighborhood is, and what type of housing. So you can distinguish, single family homes from apartment buildings from, assisted living settings. Also, again, so there's quite a few questions about health. So there's kind of the general health, this general self-rated health questions. Again, specific chronic conditions. I think there are about 15 that are asked about. In addition, they ask, if people have fallen in the past year, if they've had any broken bones, if they've had surgery, if they've been hospitalized, if they've gone to a rehab facility. And there are also questions about sleep. So if that's of interest, there are several questions on sleep in there. And then depression and anxiety symptoms are also measured. And then, as I said, functioning is a big part of NHATS. So there's quite a bit of detail about what people are doing, and then what kinds of impairments they might have in functioning. So it asks about household tasks, about specific types of self-care, and about specific types of medical tasks. And then participants are also asked if they get help with any of those things. So, if they say that they can cook at home, then they're asked, do you ever get help with cooking at home, for example? And as I mentioned before, there's some, actual functional tests that are done as part of the interview, along with a number of questions about what they're able to do, what mobility devices they use, if they have any sensory impairments, and whether or not they drive, what kind of transportation they typically use, how they get around. There's a couple of questions about technology use as well. So if you want to know about their, whether they have a smartphone, whether they use the internet, how much they do that, that's all in the data set as well. So in addition to that information about the older adults, again, this is NHATS, so this is focused on the Medicare beneficiary. They're also asked to kind of just describe their social network. So they're asked specifically about if they have a spouse or a partner, who else lives in the household with them, if they have children, who else, they can list up to 5 other social network members, so friends, coworkers, if they're still working, that sort of thing. People who help them specifically, so again, with some of those tasks that are asked about earlier in the interview. And then respondents are also asked if they take care of anyone else. So if you can also know whether or not they're a caregiver. And then there's kind of just the standard demographics section. So there's questions about employment, their income, their assets, and then all the kind of personal characteristics that you might expect from a large survey like this. So before I go into the NSOC half of this, are there specific questions right now about NHATS?
I do have a quick question. So it's not just what we call community dwelling.
Right.
It includes someone perhaps in a nursing home?
It does, yes. Yep.
Okay.
So, and there's actually additional information. I didn't put this in there, but if someone does live in a long-term care facility, there's also a separate part of the interview that happens with staff at the nursing home as well, and there are some specific questions for the respondent as well. So you can also get information about kind of, what kinds of care they provide there, also what kinds of activities they have, if there are specific types of services, for someone with cognitive impairment or for different types of health conditions. So there's actually a fair amount of detail too about if they're in, if they're not community dwelling, where exactly they're living.
Thank you. And actually, just one more thing. So
Yeah.
if someone isn't able because of a cognitive impairment to answer the questions, they're still included, those types of people can still be included with the proxy?
That's right. That's right. And I think there are a lot more details on the website, but my understanding is that, yes, so they would contact a family member and or if they're in a long-term care facility, the staff member who does the kind of residential detail form could also serve as the proxy for this information about the person's function and so forth. And I don't know enough to know kind of what the order is in terms of who gets asked, but
Thank you.
yeah, there is information on the site if you're interested in that.
Great.
Thanks, Dr. Knapp. Other questions? Okay. So then the NSOC is a companion study to NHATS. So it also started in 2011. It has not happened every year, although happily starting this year, it will be annual. So there was an NSOC in 2011, in 2015, 2017, and then again, this year marks the first year that it will be an annual survey as well, or annual interview. So same funding source, this is NIA as well. And Vicki Friedman also leads NSOC along with Jennifer Wolf, who's at Johns Hopkins. And so the way this works is, as I mentioned before, all the participants in NHATS are asked who helps them with different tasks. And they can list many people, but for NSOC will interview up to 5 of those people who help the NHATS participants. And so because of the way that the data have been collected up to this point, it was only cross-sectional. So if you use the 2011 data, 2015 or 2017, you can't link the helpers across years. So it's possible that, the same person was interviewed each time, but their data aren't connected. But beginning in 2017, there is a longitudinal component. So there is now kind of a study ID that you can link caregivers data over time. And so again, starting this year, that will continue, that NSOC will be longitudinal, just like NHATS. And so you'll be able to kind of track both the older adults trajectories along with the caregivers trajectories and understand, how changes in one might impact changes in the other and so forth. So I think it's, a good time to, to start using these data sets if these data are of interest to you from a research perspective, because I think it's already a really strong data source and it's only getting stronger with this additional longitudinal component. So what's in NSOC? Much of it, if you're familiar with caregiving work or, if you've had experience as a caregiver yourself, you might expect. So things about how much care people are providing, how long they've been doing it, and what types of things they're doing. And one of the really nice things about NSOC is because the framework for NHATS is centered around ICF and function, that kind of carries over into the caregiver side of it too. And so you don't just get the total hours of care. Caregivers are also asked, how much of that care is doing personal care kinds of activities, how much of it is helping with mobility. There's also, they ask the caregiver if there have been gaps in their care over, the preceding year, and if so, why? So you can, again, even in the cross-sectional years, you can kind of get a sense of whether caregivers are doing it consistently or if it's a sporadic sort of care. And then there are a lot of questions about the specific types of things that they do. So work around the house, managing medication or other kinds of medical tasks, paying bills, activities of daily living. There's specific questions about helping with oral care and with foot care. And then there's also specific types of mobility assistance. So it's things like, do you ever let them lean on you when they're walking? Do you ever help them up the stairs? There's very kind of specific tasks that they ask about. And then there's also questions about whether the caregiver helps with transportation. In addition to those kinds of basics about what kinds of caregiving they're doing, the caregivers are asked if they've gotten training for different tasks that they're doing and if they need more. They're also asked about what kind of support they get from other people. And so a lot of the questions are more focused on informal support and being in caregiver support groups, but some of them are about formal services as well. There are questions about the caregiver's own health and function. So that same, it mirrors the NHATS for the most part. So it's general health status, all the chronic conditions, their kind of mobility impairments, that sort of thing. I actually can't remember right now. I'm not sure that they do the full functional and cognitive batteries for the caregivers. I would have to check on that, but I feel like they don't do all of them. There's also questions about how caregivers have interacted with healthcare providers related to the NHATS participant. So, things like how often do you talk to them? Do you feel like they listen to you? Do you get enough information? Do you understand what they're saying? And then there's quite a few questions about end-of-life caregiving. So if an NHATS participant has died since the last round, but the caregiver is still contacted, then there are questions about, sort of decision-making at the end of life and how that process went. So if you're interested in, things like palliative care and hospice and just end-of-life caregiving in particular, this is a nice data source for that because it has quite a bit of information about that. I don't have a good sense of how many of those interviews happen in each round, but my guess is that it would probably be adequate just because I've seen some papers on it already. So I think it is relatively common. And then there are, again, similar demographic information, including a lot of questions about employment and how caregiving has impacted their employment. There's also information about the caregiver's household. So just like the care recipient or the NHATS participant is asked about who they live with, who else is in the household, the caregivers are as well. So in addition to all of that, there are a number of questions about relationship. And so these are kind of like how well the caregiver gets along with the care recipient, if they have, if they have issues with their relationship, more about the social and emotional support that caregivers get from other people. And then there are questions about both the positive and negative aspects of caregiving. So some of the positive ones relate to increasing their confidence, helping them deal better with difficulty, kind of in their general lives, feeling closer to the care recipient, and feeling satisfied that the person they're caring for is getting the kind of care that they want them to get. And then the negative aspects, there are 3 questions. These are each just individual questions about, have you had any financial, negative financial impacts associated with caregiving, negative physical or emotional impacts? And then there's a list of questions about whether people have given up or stopped doing certain things. And this includes, work, going out with friends, going to church, going to other kinds of events and things, or doing things that they used to do because of caregiving. And then finally, there's a set of questions that ask how much difficulty caregivers have doing specific tasks that they've reported earlier in the survey that they do. There's kind of a follow-up about whether they have any challenges with doing those things. So I have just a few more notes to those of you who might be interested in using these data, and then we can chat some more. These data are weighted because the sample is designed to represent all Medicare beneficiaries nationally. There are weights associated with the data, so you do have to apply those when you're doing any analyses. And it can get, I don't want to say complicated, but you do have to think about which data set you're using, especially if you're combining information about the NHATS participant and the caregiver. You just need to basically read the documentation to see which weights you should use, but they're all calculated, they're all described well in this document, so you don't have to do anything to create weights, you just have to make sure you're applying the correct ones when you do analyses. And so along those lines is the next point, which is it is possible to do dyadic analyses. So in other words, there are indicators in the data set so you know which person in NHATS the caregivers are caring for. So you can link those two experiences. Again, there's information about how you need to account for that in waiting if you include information from both people. And then as I mentioned before, based on the year of data, that you may need to do cross-sectional analyses, but increasingly it's possible to do longitudinal analyses. So I mentioned at the very beginning that most of these data and everything I've talked about is publicly available, free to download for registered researchers. There also is a Medicare data linkage possible. And so this is part of the restricted data set, and you do have to go through the approval process, which I have not done, so I can't tell you anything about it. But I do know it's possible. So if you wanted to actually link, and this again may get to if you're interested in a specific health condition or specific service utilization, this would be a great way to look at it, because you would have all the NHATS data, potentially NSOC data, and then their Medicare healthcare utilization information.
So that would tell you,
Oh, sorry, go ahead.
oh, sorry to interrupt. So that would tell you, like, if person X had glioblastoma, and
Exactly.
then that would be linked with these. Okay, but that would have to go through an IRB process then.
Yes. So yes, you would have to do your own local IRB approval, and then I think, again, I haven't done it, but I think you kind of submit a brief proposal to the NHATS team, and then they review it, and then, you know, kind of approve you or not for the Medicare data linkage, and they facilitate that. But again, I don't know exactly what it looks like because I haven't.
It's kind of similar. It's kind of similar to the MHOS, the Medicare Health Outcome Survey, which is linked.
Yeah. Okay.
I had to go through an IRB for that.
Yes, my guess is it would be similar, but again, sorry, I don't actually have firsthand knowledge.
Is it okay if I ask a quick question?
Yes, of
just
course.
while we're on this slide. So the linkage to the Medicare data, is that still free?
I believe so. That's a good question. It's possible that there is a fee, because they do have a data management team kind of in-house. So it may be that you have to pay for them to actually do the linking for you. But that's actually a good question, and I don't know the answer to it.
Thank you.
Yeah,
Thank you.
Sorry.
I think it may be free because that's already existing there. And then you just have to send a proposal that's unique and novel, and it shows that you're doing something that's not been done before, and then they'll give you the linked file. That's what I believe. I don't know if anybody else on the call has better information.
Hi, this is Nicole Richardson speaking. I actually, a couple of years ago, worked on an interesting study that was more focused on how to support peer groups within communities to help caregivers. But it was more that the data was focused on family-centered approaches given the cultural context of what we were studying. So there's a lot of limited data with respect to actual nursing homes and long-term care facilities, just by virtue of the fact that other cultural, I guess, importance or how they view certain things in the households are very different than how we view them here. So I guess my question is then, how do you kind of make a judgment with respect to the needs that need to be bridged in a long-term care facility as opposed to taking care of somebody who's in home? And are there separate, kinds of questionnaires and adaptable questions pertaining to the actual facility site or point of care?
That's a great question, Nicole. So I think on the facility questionnaire, you would be able to get a bit of an understanding about how much care is provided at that facility and what kinds of tasks and things they do. And then if they also reported that they had a helper outside of the care setting, you could kind of see what that caregiver was doing in addition to what the residential facility was doing. But I don't think there are, I could be wrong about this, but I don't think there are questions on NSOC that are specifically designed for caregivers who are caring for somebody who's living in a residential facility. I think it would only show up on that kind of residential facility data side. Does that make sense?
That makes sense. Thank you. Yeah, I was just curious because I realized that obviously it's advanced in the last couple of years, especially in this years ago. The data again was limited just by virtue of the fact that, it has a lot to do with cultural frameworks and where the data is actually pulled from.
Yeah, and again, there is race and ethnicity data, which isn't perfectly aligning with cultural beliefs and practices, but might give you some indication. And so that's available for both the caregivers and for the Medicare beneficiary. So you could sort of look at data in that way to see if there are differences by racial and ethnic groups. I don't actually know, I don't know if there are questions about things like nativity or, being born in the US versus outside of the US. I don't remember if that's part of the demographics of these surveys. But that might be another option to kind of look at. There's also like census level data, so you can kind of look at rural urban differences, and one of the restricted files is also a geographic file where you can get more like census tract level data, so you could also get a little bit more information about somebody's community that way if you were interested in it. Again, that would be a separate process, kind of like the Medicare one, where you propose linking it and then kind of go through that process.
Great, thanks.
So I think the only other thing I wanted to mention on this slide, because we already talked about the end of life and residential care facility ones, is there was a COVID-19 supplement done last year. Again, like most of the other data that I've talked about, pretty detailed and involved. So it includes questions about whether or not somebody was diagnosed with COVID-19, if someone in their household was, those kinds of questions, but also lots of questions about the impact on their care, on their function, on their health, on social participation. So that those data, that questionnaire, are also available on the NHATS website. And I think they just became available a couple months ago. So those are relatively new data if you're interested in kind of COVID impacts. And again, I believe that, it's the same sampling frame. So whether somebody's living in a residential care facility or in the community, they were eligible to be included in the COVID-19 supplemental survey. I mentioned this before, but again, there's data refreshes that happen periodically. So this one's just showing the 2011 and 2015, in case you're interested in getting a sense of kind of how many people are in each year, how those numbers change over time. So their loss to death is shown in this figure, and then there's also just attrition over time, of course. And so again, there's a 2021 refresh happening this year. So I don't know if it's been completed yet, but they didn't have any data up on it yet. And I just wanted to mention one more thing about the support for researchers. So again, the website for NHATS and NSOC is fantastic. There are all kinds of user guides along with technical papers on specific issues, things like dementia classification and how to weight different analyses. They also, so this is what I did this past summer, they have a summer training through the University of Michigan that uses NHATS and NSOC data. This past summer, the focus was on caregiving. So there's kind of a different topic every year. But I think there were probably, 40 of us or so that were in this program. And so you break up into teams, and the teams work on a specific topic together. You write a paper is the idea. It's just a 2-week program, and then you kind of wrap things up on your own time. But so my team and I focused on rural urban differences in dementia care by race and ethnicity as well. And so we just finished our first draft of that manuscript. So that is, again, the extent of my current experience with using the data set. But it's a great program, whether you are currently in training. So there were everyone from PhD students through, people like me, associate professors who were part of this summer training. So it was a nice mix of people across career span and interest areas and all over the country. So I think applications are due at the end of the year, maybe December or January. And then again, it happens in the summer for a couple of weeks. It was virtual this year. I don't know if it'll be virtual or in person next year. But if you have questions about that, if you're interested in participating and want to know more, I'd be happy to talk with you offline about that as well. So the last thing I want to mention is just a few of these examples of what people have done. And this is all using NSOC data with or without NHATS. So there's a paper that was looking at rollover load, so kind of caregiver burden, sleep and social support among caregivers of people with dementia. There have been kind of descriptive papers. So the second one looked more at caregiving intensity by sex, race, and employment status. And then another one, this was linking the Medicare data. So they looked at family caregiver training needs and Medicare home health utilization through Medicare. So again, that's using actual Medicare service use data on home health care, and then looking at what caregivers said they needed from NSOC. And then also another kind of descriptive report about geographic differences in caregiver experiences. And so that one was focused on rural and urban differences. But like everything else on their website, there's a great search function. So they have kind of collected all of the publications that use NHATS or NSOC data and put it in one place on the website. And you can search that pretty easily for terms that you're interested in. So whether you're looking to see if somebody's already done what you'd like to do, or if you're just looking for more ideas about how people have used these data, I think that's a nice resource. So I'm happy to talk about questions you all have now, and then my contact information is on here. I will be leaving App State at the end of the calendar year, so that email address will work through then, and then I'll be at the University of Utah after that, but I don't have an email address there yet. So feel free to reach out, or Dr. Knapp will know how to track me down if you can't get in touch with me before then.
Thank you so much. If anybody have questions, we have 5 minutes or so for questions. Actually, I had a question, but I think you answered it when you were talking about NSOC in detail. So the cross-sectional aspect of it, how does, I was going to ask how that compares to BRFIS, but it seems it's got a lot more detail than BRFIS does in the caregiver module.
Yep. So yes, the caregiver module from the BRFSS has 10 questions. And it really is, it's part of a public health surveillance system. So it's more just about kind of the hours of care duration, what the condition, the main condition the care recipient has is. And so that, yes, that one can be linked to the caregiver's other health experiences, but NHATS and NSOC just provide a lot more detail about what people are doing. The other thing I didn't put in the slides, but there are also time use diaries in both NHATS and NSOC. Wow. So if you were interested in getting into like really the nitty gritty of what people are doing and how they're spending their days, that's also possible with this data set.
Is it feasible to do research and try to get published using the 2015 or 17 NSOC?
Yeah, I think so. I'm still seeing papers. I mean, I've seen papers come out this year using, I think I even saw one come out this year that used 2011. So I think it's still fine to use them. The other thing I should note is kind of like the BRFSS, there are some rotating kinds of topics that show up on NHATS and NSOC. So I think those are probably the ones, the 2011 data that are still getting published are probably more related to things that they were only on in 2011, for example. Okay. But there is also the potential, I think doing the longitudinal since then would definitely still work. But yes, I still think the 15 and 17 cross-sectional ones are
Okay.
being well used.
And so, so 2017 included both a cross-sectional version and was also connected to the 215.
That's right. Yes. Yes. So
Okay.
yes. So there's I think I looked at it at one point and now I forget. I want to say it's maybe like 800 caregivers who have the longitudinal, but
Oh, okay. All right. Okay.
um,
And obviously the 2021 is not available yet.
right. It's not.
Okay.
Um,
All right. Well, I don't want to monopolize questions if other people have things to ask in the time we have left. Well, then I'll just say thank you.
oh, it looks like there is one more question.
Oh,
Sorry,
there is.
Bethany.
You see, just call the person if you see. I
Yes.
don't see.
So, the Hongduk, did you have a question? Maybe not.
Hong Duck. I think that's your hand raised.
It
You're
may have
on
been
mute. You're on mute if you're trying to talk.
Oh, hello. Yeah, thank you. Yeah, very
Sure.
lovely talk. And yeah, I'm appreciative. And I'm not sure you can answer or not. I'm just curious. What you are the interpretation of the result between the you just quick shown to the 2011, 2014 versus 2015 versus 2018 data. Looks like slightly the data the kind of based on the Medicare data bank size of a little bit different. And then overall, what is your interpretation about the care quality of care is change depend on the urban versus the rural versus also geographical difference? Did you find it? Could you tell us about that?
I think that the paper that I linked on there that looked at kind of rural urban differences overall, there were some differences, but not markedly for rural and urban caregivers. So they tended to be pretty similar in terms of what the type of care that was being provided, hours of care, that sort of thing. Maybe not surprisingly, I think the services, like service availability and use, was lower in rural areas than in urban areas, but that wasn't even across the board. And then I think I actually haven't seen, and you were asking about change, like the changes in caregiving experiences across time.
Yes.
So I imagine somebody has looked at it, but I'm not sure I've seen that analysis done.
Okay. That's
so that's
fine.
a good question.
Oh, okay. Yeah, that's fine. Yeah. Also, I have quick one more question. You already mentioned the kind of the positive and negative aspect of about this kind of caregiving, but I'm just worried. I just concerned about the quality of the care training the program. That this is kind of the nationally the protocolized or some government provide to us, or the based on this kind of the NHATS or NSOC the study, they needed to more improve to customize or the personalize or the depend on the the two studies based on I don't know what the detail about the subject the type kind of the oldest and then most of the black population the Michigan and then the Michigan and then the Baltimore. And I don't know in general there is some that depend on variable the lifestyle and the Caucasian, the Asian, and also the black people, Mexican are different, right? And how we can the standardization about this the training of the caregiver.
Yeah, I think that's a great question. I'm not aware of any, like HRQ or anyone having kind of quality measures for caregiving specifically. And so the questions that are in here are more, it's more caregiver perceptions of whether or not they feel like they got enough training. Some of the questions are specifically, like at discharge from the hospital or when this person was diagnosed or, when you took over for home health, did you get training on how to, change the wound dressing or on whatever other tests. So yeah, it is more self-reported.
Thank you so much. Yeah, I appreciate it. Yeah, thank you.
So they in NHATS, you learn whether or not a person says they have a caregiver. And that's the only thing you learn about, you don't, there's no follow-up question of that respondent. Are you satisfied with the care you receive or stuff like that?
That's a good, yeah, actually, that's a great question. That would be a good way to get at. I don't believe so. I believe I mean, I think they say what they get help with and who helps them with it, but I don't think that there's a follow-up on that end.
Okay. Well, I'm trying to take the lazy way out and not
Yeah,
read it myself.
I think that would be a great way to do it. I could be wrong because I'm still learning this data set, but I don't remember seeing that in there.
Last chance if anybody else has a question.
I have a quick question. Sorry,
Yes.
I'm not even on. Okay.
That's okay.
Sorry. I'm just wondering, I'm sure this is probably not relevant, but is there any way to link this to drug formularies, medications lists?
Good question. So I think Medicare has a prescription. I think you can get prescription information, but I imagine that also depends on, whether they have Part D coverage and, it may not capture everyone's.
Elizabeth, that MHOS, the Medicare Healthcare Outcome Survey, which has some of these questions about function, is linked to Part D Medicare. So if you go to, so you can link that information.
Yeah. It's just like you need it all in one place, I think.
Right.
Yeah. Okay.
Yeah, and I don't know if it's possible to then link to the outcome study, for folks in this study, but
I will be following up. I think this looks very interesting. I've been looking at the site as you've been speaking and leading us through it. Very interesting.
yeah, I think it's an incredible resource, and I'm hoping to jump in more too. So
Thank
we
you.
can have a follow-up work group conversation about what we've all found.
Perfect.
Be great. Well, Dr. Bouldin, thank you so much for your generous time, and really appreciate it. And everybody be safe and stay happy. And we'll upload the recording of the webinar on our Center for Long-Term Care website within a week or so.
Thank you all so much.
Thank you.
Take care.
Bye. Thanks a lot. Bye.